I now invite Professor PANDAV, who's really spearheaded all the glaucoma surgery that we do, and we've all learned from him. So he'll be taking an overview and expert comments in Bleb management.
Sir has to go for another section, so we have changed the sequence.
Sorry for changing the order. I think Bleb management is very important because even if you do a perfect surgery, whether your surgery will succeed or not, it depends subsequently on how you manage the blebs. And objective of glaucoma surgery, of course, is to have a diffuse functioning bleb and also which lowers intraocular pressure. So this is a nice bleb. Actually, you don't even see where the bleb is, and conjunctiva looks almost normal. It's very shallow bleb, very diffuse, and pressure is 12 millimeters of mercury, and you can see the conjunctival vessels are there. It's not ischemic bleb. So this is the perfect bleb actually that one can have. But very often we have nightmares, and unless we understand how get into these situations and how can get out of it is important. So bleb management actually becomes very important in the post-operative period. And there are two aspects to bleb management. One is manage the complications, because complications are known with trabeculectomy, and we need to recognize and deal with them as soon as possible. And also other is to prevent the bleb failure. There may not be a complication as such, but the blebs may not function properly, in the post-operative period, or they can fail in a short time after surgery. So we need to keep that also in mind. Now this is two trabs actually, two different eyes. They have underwent exactly the same procedure by the same surgeon, very similar patients. And this is day 2 post-operative, and you can see these actually look very similar. So the AC is nicely formed, the pressure is 10, 9 or 10 millimeters of mercury in both eyes, and I'm very happy, to see this on the day 2 post-operative period. But as we go along, you can see on 7th day above and on 14th day above, you can see there are differences in the two A and B eyes. So the A eye, you can see some vascularization there. So this is, okay, so there's some vascularity here, is there. And this is becoming a little more down there, but the bleb B actually is not changing much. It looks like the same. And very often when I ask people which bleb do you think is better, very often the answer is B, because we are taught that you should have a little, pale, thin, looking bleb, not congested bleb. But that's not true. Actually, that's kind of a myth to some extent, because if you look at that, this is the bleb A, which is beautiful, 10 millimeters of mercury pressure, and the bleb B actually has become a tendon cyst with high pressure. So this indicates that the bleb healing, the wound healing is actually very different in different people. This is just because there's a difference in the healing in these two eyes. So wound healing is very important, and that needs to be kind of understood, and you have to modify it there. So when you're dealing with the blebs, what are the risks of bleb failure? So there are many risks, like you can deal perioperatively or post-operative, which have been already discussed. But I am just talking about the post-operative period. Now you have done trabeculectomy, you have a bleb, and how you do identify that which are the blebs which are a higher risk of failure and which are a little lesser risk of failure. So if you have a shallow AC hypertonia or wound leak, they have a moderate risk of failure. If the bleb is unusually high, is a normal functioning bleb at that point of time, pressure is good, but it's kind of a higher than what you expect. So that has a higher rate of failure. So that basically means because the aqueous is actually getting pooled in the subconjunctival space, so it's not flowing very freely out of that space. So that's why there's a moderate risk of failure. So you have tendon cysts, moderate to high risk. The bleb vascularity, as mentioned, is higher risk of failure. But again, there's a bleb vascularity is kind of, you have to qualify this. So there are two kinds of vascularities. One is a good vascularity and one is a not so good vascularity. So you have to clinically differentiate which one is good and which one is not good. And then, of course, if the bleb area is getting reduced progressively, you have a large bleb and then getting progressively decreasing, and that also is a high risk, is a strong indicator of bleb failure. And then you have a high IOP, and there's a bleb which is high, and IOP is high. So if you have a bleb which is there, that means it's not actually working, it's not functioning, there the pressure is high, and that is a very strong indicator for bleb failure later on. So the question is, how do you manage these risks for bleb failures? So most important thing is in the immediate post-operative period, I think inflammation is very common, and inflammation actually sets the tone for rest of the wound healing. So there's a lot of inflammation, there's a lot of fibrosis, and that, so you have to contain it. And you can see there's a lot of fibrin there, is almost like hypopion-like picture there. So you have to be careful here, so you have to rule out infection and treat cautiously. But this one kind of responded very well to the usual treatment. Other thing is that if there's a shallow anterior chamber, then again you have to rule out wound leak, choroidals. This is the eye on third day post-operative. You can see the AC is actually shallow, but bleb is there, is overfiltering. This is a limbal-based, bleb there, and you can see there's a very large diffuse bleb and is overfiltering. Now, what do you do in this situation? I think the most important thing is to be patient with these patients. If there's no wound leak, there's no choroidal, just wait and watch. There's no need to get into the eye quickly, especially if the eye is quiet and if there's no undue inflammation or wound leak. And then you just wait and watch, and in 4 or 5 days' time, you can see the bleb is forming. Of course, if it doesn't show any sign of improvement over the period of time, then you might have an indication to go in, or if there's a AC is totally flat, or if there's a corneal decompensation or something happening, then you would go in and reform the anterior chamber. But by and large, most of the time, if you just have patients, wait and watch and treat with steroid cycloplegics and antibiotics, and that should be fine. And if there's a choroidal detachment, again, you could have shallow ACs. Again, patients with some steroids, and most of the time you'll get away with the situation unless you're very large kissing choroidals where you might have to intervene early. But it's very rarely that you have to drain choroidals after filtering. So sometimes we have to do, but usually they respond very well to conservative therapy. And then is the wound leak. I think this is important to recognize and address the wound leak as soon as possible, because what happens is that if the small wound leak is going to eventually heal itself, because the body is going to heal it. But by that time, the rest of the bleb will, kind of stick, the conjunctiva will stick, there will be fibrosis, and your bleb will not form. So once the wound is healed, the pressure starts going up. And as long as the wound is leaking, there's a hypotony. So this low pressure, it suddenly goes up very fast. So I think it's very important to recognize wound leaks and seal them. So this is the wound leak. Actually, this is a very thin conjunctiva there. And the wound is actually the suture tract which is leaking, because when you pass a needle, this was a continuous suture on a limbal-based flaps, and this, you can see these are the suture tracts which are leaking. So what I did was I put a few mattress sutures there, and you can see that area has scarred with the sutures, but the rest of the bleb is rescued. So you have a good filtering area, and there's a small scarred area which is not working, but overall the IOP is very well controlled. And sometimes the leaks may not be very obvious. So here, very nicely formed anterior chamber, everything looks good. There's a bleb there, and it doesn't seem to be anything wrong. But you put a fluorescein strip there and just watch it carefully. And there's a little bit of ooze there, which comes, and sometimes it's not there. So what happens is that when your pressure builds up a little bit, there's a leak, and when the pressure is released, there's no leak. So I think you had to watch for these eyes. And remedies are very simple. You just have to tamponade that area, just put a contact lens there, and after a couple of weeks, just leave the contact lens there, and after a few weeks, the bleb should be okay and the IOP should be good. And sometimes the bleb doesn't form at all. In that case, we are using releasable suture, and this is how I would release the sutures. Basically, just expose the suture with a needle and grab with the forceps and just pull it out. So this is how the releasable suture works. Now, sometimes the bleb may form spontaneously, but sometimes it may not form. So if you want to have more bleb post-operatively after, with or without release of suture, actually what you do is you just give a little, use the lid margin to, to press the posterior lip of the flap that you have made, and you can see the bleb is now coming up. And you can actually go very gently, very gradually, and you can decide how much bleb, how much fluid you want, how much high bleb you want, and then you can see there is some fluid is already there. So you are happy with that, and you can stop that. If you're not happy, you can press a little more, massage it a little more, and you'll get a little more bleb there. So that way you can actually regulate. The other risk factor we talked was the high bleb. Now, if you look, this bleb only doesn't look very bad on the left side. But important thing is to note here is that you have their vessel. It's not totally vascular bleb, but what is unusual about this bleb is these hemorrhages. So when you these particular kind of hemorrhages in the bleb, it's not a good sign. It indicates that there is an ischemia in this bleb, and you have a fluid which is getting collected underneath, and it's sort of is getting walled off. And in a few days' time, it will evolve into a cyst. It may become a complete tendon cyst in a few weeks' time. So if you see that kind of a appearance in the post-operative period, usually in the second or third week, I think you need to watch them carefully, and you might have to manage them. And the management would be to make sure that you have adequate anti-inflammatory therapy. Keep the IOP lower, because the IOP will cause stress because now the fluid is getting collected there. So it leads to mechanical stress, which leads to proliferation of the fibroblast. So the more the stress, the more will the fibroblast proliferation, so they'll become worse. So you reduce them and lower IOP and massage the bleb so that you can actually diffuse it. So this was the vascularization I was talking about, the good vascularization, bad vascularization. Look at this eye. These are the normal vessels. Now this looks vascularized, but this is not a true neovascularization. These are the normal vessel, congenital vessels, which have opened up because of the surgical stress hypoxia. And they are all radially placed, and there you have normal conjunctiva in between. But the bad vascularization on the other side. Now these vessels are deep, they are all over, and they are crisscrossing, they're going in all directions, they are not falling in a particular direction, and they give that red hue, angry looking. So if you can that kind of vascularization, this is bad, and this kind of vascularization you don't have to actually worry about. So don't go into overdrive if you see this kind of vascularization. And of course, the reducing bleb area I mentioned earlier is getting reduced, then that's another sign of failure. So to summarize, the aim is to stabilize your anterior chamber as early as possible, attend to the postoperative complications promptly if there are any, recognize bleb failure and its importance, and it's important to monitor bleb appearance, extent, height, vascularity, IOP, leaks, etc., and take appropriate measure in the postoperative period. Thank you.